Good morning, everybody. Welcome to PCC meeting for Hayward, Middleton and Rochdale. Stacey, could we just have apologies, please?
Yep, we've got apologies from Shabnam Sardar and Steve Rumbelow.
Thank you. And for the record, Alison Kelly's joining us later, about past. So we won't be caught till Alison joins. Any declarations of interest anybody wants to highlight? No. Minutes from the previous meeting, just in terms of accuracy, are there any amendments anybody would like to make to the minutes from the previous meeting? No. Okay, thank you. We'll take those as an accurate record. Thank you, Stacey. Actions from the previous meeting. There are two actions, one for Steve Rumbelow, who obviously can't attend today, one for myself. They're both around ours. So I'm proposing that we pick them up with that agenda item and paper later on the agenda. The other action was Sarah to invite Mojiva to the meeting chaired by Venk regarding care homework. I presume that's been actioned?
Yes, it has. That's been completed.
Thank you. Nadia?
Can I just ask, Jonathan, sorry, just make sure I'm off mute. You've referred to ours. I know what that means, but I don't know if everybody, given we're live streaming, does know what ours means. So do we just need to say what we mean? Sorry.
No, that's fine. It's fine. I think it's referenced in the minutes. So that's the additional roles and responsibilities funding that's available to primary care. And we'll touch that in the paper, but good point. Thank you, Nadia. In terms of an action due from the, he's not due till April, so we'll pick that up at the next meeting. So, Sarah, could we go into agenda item 1, please? Which is the, oh, sorry, just to say there was no chair actions. Could we go into the improving access paper, please?
Yeah, but that one's for a decision, I think, John.
Okay.
So do we need to defer that till Alison arrives?
Yeah.
Yeah.
We need to approve the risk register. So again, I think we'll skip until Alison arrives. So could we go on to the GM Integrated Care System Primary Care Blueprint, please?
Yes. So yeah, just to the purpose of the paper is really just to update the committee on work that started sort of early January and has now started to progress at pace really regarding the development of the Greater Manchester Integrated Care System Primary Care Blueprint. So the aim of the blueprint is really to set out a direction of travel for primary care and the commitment from GM ICS around that. The remit of the scope of the blueprint is covering all 4 disciplines of primary care. So that includes optom, dentistry, pharmacy, as well as general practice. The work is being led by Rob Bellingham, who's the Director of Primary Care at GM. And the blueprint is informed really by one national document, which is the Fuller Report, which was published last May, which sets out a set of recommendations and intentions about integrated primary care and the future of primary care, and the emergent integrated care ICP strategy that's been developed across GM as well. So the blueprint is made up of 9 chapters. Each locality, the 10 localities across GM, has been assigned responsibility, really, if you like, for developing a chapter. So for HMR, we've got a workforce chapter, and I'm heavily involved in this. And they've put in place what they call a triumvirate leadership approach for the development of those chapters. So that would be a locality lead, which I am the one for HMR, and working with a colleague from the GP provider board across, primary care provider board actually across GM, and a member of the GM central team. So the aim is that the blueprint will be developed and recognised by all key stakeholders. It's not a document that's intended to be written in a dark room. So there's a huge amount of engagement going on. And one of those steps today is sharing that paper with you today. And in the hope is that everybody will contribute and influence the development of the document. so far the chapters have started to outline their approach and some of the key questions they'd be looking to answer as part of that, because the aim of the blueprint is really to analyse and look at some of the issues that are facing primary care under the themes of the chapters and try and put forward some solutions to those problems. So we're still very much in development. So what you've got attached as part of the paper that everybody's hopefully had a chance to look at is the scope. We're calling it a scoping document. So that includes sort of like a summary from each of the chapters around the questions and the areas, and a bit of an outlined approach about how they're going to take that work forward and develop it. So this is going to through their engagement process. So we are linking in widely, as far and wide as we can, with lots of system partners across. We've been to some of the provider boards already. We're inviting individual feedback and obviously doing wide engagement at localities as well, and with all providers. So we're sharing with the committee today, really, just to make you aware of the work and to give everybody the opportunity to comment and influence it at every stage. And because the outputs of this work will help shape some of the work and the future work of this committee as well. So I'm paused there and happy to take any questions or anything. And it is very much a scoping document at this point in time, so it's still in development, but happy to take any questions.
Thanks, Sarah. And it's really useful, and it's a good start for a scoping document. Covers a lot of the issues that we've got on the agenda. Is there any initial comments anyone wants to raise? And if not, could you, Nadia, sorry.
That's okay. I just wanted to flag that obviously I've talked to Sarah about this, but my understanding is this is linking into the emerging GM strategy overall, isn't it? So there's sort of two pieces of work happening in tandem. Just wanted to make that connection. I think it's really helpful for us to have that here, and for us to maintain obviously our involvement in it. So Sarah, it's really helpful to hear about us having the lead on the workforce chapter. I suppose I'd be keen to hear about how else we can influence that as a locality, linking with the other people that you've been given to link with. So that's really helpful. Thank you.
Thanks, Nadia. So I think the place there is for people to obviously have a read of the document,
yeah,
and if they've got any feedback, to pass it on to you as soon as possible.
Yeah, that would be great. Thank you. And I'm happy to arrange follow-ups and one-to-ones if people would prefer a discussion around that, just a way to gather initial feedback. And there will be some more formal invites and things coming out around the workforce chapter as we expand that engagement piece. But I think we are trying to coordinate as well, because we're very conscious there's 9 chapters and there'll be different people, and we'll be going to the same people to get feedback across the 10 localities. So we're going to try and coordinate that approach over the next six weeks or so we can not take up everybody's time, but give everybody the opportunity to influence and contribute to it as well. So
with that time frame, we'll be able to bring an update to this meeting next, won't we?
Yes, yeah, we'll bring it. Yeah.
Okay, fantastic. If there's no other questions, then I'll move on through the agenda and go to workforce, which I think Greg is going to present.
Yes, good morning, everybody. So just a quick update around workforce in general in HMR, starting with the additional roles reimbursement scheme. So just before Christmas, there was a stock take by GM Central Finance team around the ARIS roles to look at where PCNs were spent against their budgets for 22-23, and there was identified a lot of underspend across a lot of PCNs for many different reasons to do with recruitment. So what we had to do was work with our PCNs to bid essentially for this underspend, so we could continue to recruit to these roles to expand our primary care teams and our primary care workforces. The good news is that the bids were successful for the vast majority, and these are articulated in the table. So this enables us to draw down that money, keep that money within HMR, and get recruiting to these roles. We also had a bit of a pilot bid for some health and wellbeing coaches that would be a HMR-wide piece of work to develop those roles. However, this was rejected by GM because it didn't meet the criteria of the ARIS roles. So there will still be an underspend in HMR in the region of about £620,000, of which will go back to GM, and we're not totally sure where that's going to go. There'll be a much vaster underspend across GM. We're actually one of the better localities in this. The the reason for this is there is still no flexibility or much flexibility at all within this programme. It's a reimbursement scheme, so these people have to be in post. It's not a non-recurrent pot of money that we can just draw out and spend over the course of the year, sort of thing, like other pots of money. It is very much a reimbursement scheme. So when that person's in post, you draw down the money, and that is where it goes. We're still awaiting guidance and budgets for 23-24, which will shape our future plans and our future recruitment. There is an anticipation that the budgets will go up by around 37%, but we're waiting for that in writing, as well as if there will be any more flexibility moving forward as well into different kind of roles, being able to do things slightly differently, which I know we've spoken about a lot with some of the digital roles in HMR. And the formal contracts of the ARIS stuff for 2024 isn't out yet as well. So a little bit of uncertainty, but the work we've done since October, getting adverts out, people into posts, claiming down, drawing down of this money, has been really positive, and we are definitely heading in the right direction. A more general update towards the end of the paper is just around workforce in general with primary care. Obviously, we've got our Primary Care Academy who work closely with all of our PCNs to help develop, retain, train staff over the course of the year. And this is some highlights of what they've achieved during 22-23 as a whole as we come into mid-Q4. And we'll be working with them going into 23-24 to continue to work up their work plan, to continue to deliver the high level of training and support that they do across all our practices. So happy to pause there and take any questions.
Thanks, Greg. I think firstly, well done to the team and to our primary care colleagues. If you consider where we were in October and the underspend we were predicting against ours, to be down at 600 actually is really, really good. I share your, I will say from my perspective, sort of exasperated a bit with the process and what we can and can't use the funding for, and the lack of flexibility. And I think going back to the two actions that were open for myself and Steve, we have pursued those conversations and not got very far is the honest answer, because of the restrictions from the national team, which is really disappointing, because there were things that we probably could have done with that resource. Has anyone got any questions for Greg on that paper, please? No. Okay. Thank you very much, Greg. Sarah, back to you for winter pressures, please.
Thank you. Yeah. So again, this is just another update for the committee around. We have been working very hard with all our provider partners as well to mobilise a number of schemes to support winter pressures. There's been various pots of money released at regional and national level since sort of the beginning of November. So I'm just going to do a bit of a summary and run you through, but there's a lot of detail in the paper around what we've done. So to date, sort of early in December, we were able to use the first tranche of funding that we got from GM to extend the opening of our existing enhanced primary care hubs. So previously, before the big December, they were open from 12 p.m. till 6 p.m. in hours, offering additional face-to-face GP appointments to all HMR residents for urgent on-the-day primary care needs. We were able to extend them till 10 a.m. So that went live from the beginning of December. And we were also able to put some additional PMP input in, which is paediatric nurse practitioners, to support with some of the, we know we have the strep A issues and some of the respiratory issues with children across there. But that extra support commenced early in January. So we've been able to put an additional paediatric nurse clinic appointment in as well. We also, which the practices were great, really rapidly mobilised, were able to provide additional capacity in hours at practice level. So that was up to an additional 30 minutes per 1,000 per week, per registered patients per week. So that's put a lot more capacity in at practice level. And we've had really positive feedback from practices regarding that it's helped them manage the demand over the winter, and the practices are all 36 are engaged with that scheme now, and they've all been able to mobilise really rapidly. So that's been in place from early December and will continue until the end of March. We've also commissioned an extra ABS car, which supports our acute visiting service, which will support general practice when they get really busy during the day. There's an additional car supplied by Bardock to go out and do some of the urgent home visits in the afternoon. So, and that commenced in January as well. And that's been able to flex up and down as we've seen the pressures increase. So all those schemes are mobilised, and we are reporting on them through SORT and through LCO SMT. And there has been really positive feedback from our providers and practices and patients around that extra capacity that's gone in the system. We also received another pot of national funding, or the opportunity to bid for another pot of national funding to help primary care surge planning, which was around the implementation of acute respiratory infection hubs. So that opportunity came early January. There is a national set of criteria that defines how the acute respiratory hubs should be set up, and the ask again was to mobilise very rapidly, because this funding is only around until the end of March. So working with our local providers, we felt that the most sensible and the quickest solution to do that was to extend our existing enhanced primary care hubs, because they are already the place where we managed our acute infections and that acute urgent on the day primary care demand. So using that funding, we've been able to extend the opening hours of that hub to meet the national criteria, because the national criteria for respiratory infection hubs is that they're open 7 days a week and on weekends 8 till 8. So that's 12 hours a day on the Saturday and Sunday. So we have put that in place, and that's due to go live this Saturday. This weekend will be the first weekend that the hubs are extending those opening hours. And again, that will be in place. We're hoping that will be able to stay in place to cover the Easter bank holiday as well as we go into early New Year, because we know we've got another 4-day weekend as we go into April. So we did get another opportunity to bid for some further funding that again was released at GM level. So that's a further 5 million at GM level, and the request was that we put bids in for schemes again that could mobilise very rapidly and make an impact on the winter pressures. So the request was that we submit our bids by the 31st of January. So we did. We've submitted 4 schemes, and they're detailed in the paper that you've got, and we are still waiting to hear because they need to go through the approval process at GM. So we are anticipating that we would get feedback around those schemes and a potential allocation of funding at HMR by Tuesday next week. But we have linked in closely with all those providers, and most of those schemes can mobilise very rapidly as soon as we're confirmed we get the go-ahead around that funding. There is another pot of money that has been available through the local authority route, and that's with the focus on supported discharge or admissions avoidance schemes. And we are engaged with our primary care providers, including out-of-hours providers and RHA, GP Federation and practices, to put forward some ideas for that. And we've just got some early discussions around early supported discharge scheme, some support for palliative care at the weekends, and potentially some development around care home scheme, but we're just working through those as we speak. So that's a bit of a whirlwind tour of the things that we've put in place. But the upshot is we've been able to put extra face-to-face GP capacity in for our appointments, which has been well receivve by public and the practices, and help them manage a really, really busy winter period. And because our hubs also take referrals from UTC and NHS 111, it's been able to support that flow across the system as well. So the feedback from LCO colleagues has been really positive as well. So I'll pause there and take any questions.
Thanks, Sarah.
Okay.
So I recognise that was a whirlwind tour, but thank you. There's been an immense amount of work that's gone on behind that, and really positive that we've been able to get some of those funding streams into Rochdale. Mo?
Just a quick thing, the feedback I'm getting from GP surgeries is that they're really struggling to get appointments with the community paediatric team. And it'd be interesting to find out how is the capacity being filled, and is it coming from urgent care, secondary care, primary care? Where's it coming from? Because I'm getting a number of complaints from surgeries to say by the time they open the phone lines at 8 in the morning, the paed appointments have gone.
Yeah. Do you want me to respond to that initially, Mo? But we do follow it up, and we do link in really closely with them because there's a number of schemes. But the paediatric nurse appointments, they're 30-minute appointments because it's support, it's a forward planning scheme as well, proactive as well as reactive. So there is a limited number of appointments, but we are tracking that capacity. But as everywhere's experienced some workforce difficulties, I think there have been periods, certainly days where staff have been off sick. So the additionality is not as obvious then, because we've obviously got staff out of work as well. But we can follow that up and provide further detail. But the routes at which because GP practices can direct book into those P&P slots now, but we do appreciate they do go very rapidly in the morning, don't we?
I think the other thing, Sarah, if we can confirm, I've been informed that those appointments start at 7:30 in the morning, but the GP surgery is only open at 8 in the morning. So I'm just wondering, do they get filled in that half an hour? And are they accessible to the general public who are using them, or who's using them?
No, my understanding is the route in to book them is through your general practice, but what they do is that what we've agreed with them is they regularly reduce additional slots during the day. They don't make them all available first thing in the morning. They're released at staggered points during the day. So we can revisit it and make sure we get some clearer comms out to practices, because we have done a raft of comms to make sure that they need to check back, because slots will be added on and will come available throughout the day to try and avoid that, you know, potential for bulk blocking and then getting really booked up early in the morning. But yeah, we'll follow that up now. Thanks for the feedback.
Yeah, let's make sure practices know that they're not ringing up first thing and then all the slots become available during the day. But I'm sure you've been putting comms up.
Yeah.
Okay, thank you. If there's no other questions, Damien, could you update on the finance report, please? You're on mute, Damien.
Is that better?
Yeah.
I'm so sorry. Thank you very much. Thank you, Chair. I don't propose to go to spend a long time on the finance report. I think, as has been raised previously, the main issue that we're finding within primary care and the locality budgets is the prescribing. So the prescribing pressure is primarily due to an increase in prices, the price concession, on top of obviously the drug tariff that we pay for the prescriptions, which is being seen right across not just the ICB but nationally. So due to the shortages in stock, etc., the increase in cost has then obviously been passed on, and we pick those up. So at present, we are looking at a 698k pressure at the end of this year on prescribing, which has been partially offset with some fortuitous underspends from Q1 being passed through to this year, to bring us down to 645k. There's a lot of work that's being undertaken essentially at GM at the moment to understand what this looks like and how we can go about mitigating this pressure, because obviously at a locality we can do very little. So it has been raised at a GM level, and I believe they were looking to raise this nationally as well. And I guess that really is the crux of the report and the issues that we are facing at the moment. So if I can get you back on, are there any questions?
Thanks, Damien. So yeah, just to reiterate, it's the issue at the moment is not necessarily an increase in prescribing, it's the national price of the prescription drug. So we're feeding that back through the ICS back up to the national team. But you know, the medicines management team, social prescribers are doing a really good job managing prescribing, but unfortunately it's a cost of inflation and price. Lovett, do you have a question?
Yeah, it's just a quick comment for you. From a community pharmacy perspective, you know, we had a record number of price concessions that were announced in December. I mean, we're talking about 160. It's unprecedented. It used to be maybe 5 to 10. And unfortunately, you know, having looked at the data and having linked with PSNC, the national negotiating body for community pharmacy, these price concessions and supply issues, you know, out of stocks, for example, are going to be on the increase in the coming months. And it seems to be a pressure from the pharmaceutical suppliers of the drugs that are incurring increased costs, basically, especially for generic medicines. So you know, we are looking at developing GP community pharmacy interface principles, and there's been discussions about potentially rolling out patient-led ordering, for example. Do you know what I mean? To kind of streamline that, because the capacity in community pharmacy is significantly challenged, and we recognise that, and actually promoting that self-care and that messaging to patients, and actually being able to direct that patient-led ordering to some degree may actually help, based on the data from pilots from other areas, may help to kind of release that cost pressure that the ICS is facing. But I can provide more details offline about that with regards to discussions we're having with the ICS, Primary Care Systems Operations Board, and other models that are being used in other localities at the moment. Thank you.
Yeah, that'd be really helpful if you could share that, please. Yeah. Any other questions on the finance report? No, I'll move us on. Thanks, Damien. So in terms of the IT report, again, I'll take it as read. You'll all be aware that we have a separate IM&T board that meets bi-monthly and is GP led and chaired. What I would raise is obviously Milne Row is due to go live in the very near future, and we are just sorting out the furniture and the IT. And we hope to go live at the end of March-ish. I believe there's a couple of walkarounds due to take place in the next few weeks so people can see where they're up to. So the IT team are supporting that fit out and getting that operational to go live. But a really good piece of work and an important building for the residents of Rochdale. Any questions? No. I'm hoping Alison's going to join us any minute. So I'll just touch on the public questions because that's for information. So to say, we have had a question from a member of the general public. As you'll be aware, for the questions raised by the general public, we now have a process in place, and we will answer that question in the allotted time, which is 20 days. The question centres on mental health and some of the mental health issues in Rochdale. So we will work to provide the answers to the public within 20 days of receipt. I'm just going to jump to AOB to see if anyone's got any AOB. No.
No. Is the
Okay,
estates
brilliant.
update on, Jonathan? Do you wanna
Sorry,
do-
say that again.
Is the estates update on? Do you want to do that briefly?
Sorry, I jumped over that,
Just
didn't
for
I?
information, yeah.
Apologies. Greg, is there anything you want to update on estates?
Just a couple of quick points. You've touched on a couple. We continue to work with GM. Piece of work was commissioned around a PCN toolkit, which is set into a number of waves, and Pennines have gone through most of wave one now, where you have facilitated meetings to develop a clinical strategy for your PCN to look at areas of focus, key risks in your PCN and your population, how you want to improve primary care access and things like that. So that's been a really good piece of work. And then the second phase of that, it starts to map your clinical strategy against estates and what you might need going forward. There is a little bit of money attached to this second part of the programme, which I'm looking forward to getting into. Not masses, it will be more looking at utilising space in existing practices and maybe doing some revamps of certain rooms to get more clinical access. But as I say, that's wave one. Pennines have gone through the vast majority of that, and the rest of our PCNs will be in wave two and wave three as this commences into the spring. There's also just wanted to flag a wider piece at GM level around utilisation of existing sites and assets across GM. And I think this will give us a really good picture of what sites are available, where there is lack of utilisation, where we can try and get primary care more out into the community and be able to offer more services, if you will. As we know, money is tight, so looking at what we've already got and being able to flex that as best as possible and having a GM level overview, I think will be really helpful. And lastly, just Jonathan's already mentioned it, the Milne Row Hub looking to be on track for the end of March. We've supported it with the fixtures and fittings, and the IT stuff is going on as we speak. And there is a visit at the end of the month that myself and the primary care team will be attending to see that new site, which is very exciting. But other than that, that's everything in the estates.
That's great. Thanks, Greg. And just for your awareness, this will also be taken through the Strategic Estates Group for Rochdale, so that we have the oversight of that group. Any questions for Greg? No? Right, I will go back now. We'll call it to item agenda 6, which is for approval, the Improving Access Enhanced Primary Care Hub Sunday and Bank Holiday Evaluation, please, Sarah.
Thank you. Before we start, because I think Mo joined after we'd done the declaration of interest bit at the beginning. So I think because the hubs are currently run by RHA, there's probably just a conflict that we'd need to note, I think, for the minutes, and then you won't be able to participate in the decision, I don't think, Mo. I think that's how it works.
It is. Thank you, Sarah. Yeah.
So yeah, so we currently have 2 services that are providing additional general practice appointments to HMAR residents. Both of these are currently only funded until the end of March 2023, so that's not too far away. And this paper provides an update on the outcomes of the evaluation that's taken place for both of those services. And today we're seeking the committee's agreement for the reasons outlined in the paper to prioritise and support the continuation of these services beyond the end of March. So I think there's detail in the paper around the outcomes of the evaluations, but essentially both services have been well utilised and really well received by public and our providers, and support our wider system. There's a mix of the Sunday and bank holiday service provides a mix of urgent on the day appointments and routine appointments, and that was commissioned to plug a gap that was left with some of the national changes with the PCN DES taking over what was previously known as the 7-day access service, because the core requirements for that service are only to cover the Monday to Saturday, whereas our residents have been used to having a service on a Sunday and covering the bank holidays. So that's why that one was commissioned as a 6-month pilot. And the other service is the 2 enhanced primary care hubs that I mentioned previously as part of the winter pressures update that currently operate 10 till 6 p.m. Monday to Friday. So I'll pause there and take any questions, really. So it's just we're seeking the committee's support around continuing those services beyond the end of March.
Yeah, I was going to say, so to be clear, what we're asking the committee is that following the feedback, following how successful the service has been, we are seeking your agreement to continue. We need to look at a source of funding because it's currently funded non-recurrently, and obviously there'll be a process for how that is. Can you still use the word commissioned? Commissioned from a provider. But I think for today, for the committee, is these services have been really, really valuable to Rochdale. Feels like I'm trying to lead you to the answer, but I'm not. Just giving my opinion, and that we're looking to seek agreement that we continue. So I'm going to kick off and say I agree.
Thank you.
Alison?
Yeah, I would agree that that's the way forward to carry on.
Thank you.
Thanks, Alison.
Anybody else got any issues to raise, or we'll take it as agreement there, Sarah, to carry on?
Thank you. That's really helpful. The next steps are outlined in the paper, so I think we'll progress now with that work around. We should be able to combine them into one offer to try and make some of the commissioning arrangements a bit simpler going forwards, and then we'll source the sustainable funding as well, as Jonathan mentioned.
Brilliant. Thank you. Greg, can we move on to the risk register, please?
Yeah, sure. So no changes to the risk register scores, easy for me to say. Updates are in the attached, just to flag a couple of mitigating actions that we continue to work on to mitigate some of these risks. One is around the increased accessing capacity. So what Sarah alluded to in her paper around winter pressures and the extra funding we're bidding for, putting on these ARI hubs, all helps towards contributing to that risk around access in primary care. Obviously that risk is still there, but doing these types of initiatives and schemes really supports that. And on a similar topic, we've been working with BI and partners around creating a primary care dashboard that we've not really had before in terms of all the data in one place in terms of access and referrals, and this will really support the system and our GPs to demonstrate the demand and activity and help us make future decisions. So no formal changes to the risk register or anything added, but work continues to mitigate the risks that are on there, and the paper is attached for your perusal. Thank you.
Thanks, Greg. So just from the committee's point of view, it's just to acknowledge the risks and the work that's ongoing and the mitigations. Has anyone got any questions on the risk register, please? No. Okay. That's the agenda complete for today. I just want to thank everybody for all the hard work. We go through those papers quite quickly sometimes, but there's an amazing amount of work that goes on in the background. So